LPFM in New Orleans. We are Radio NOLA HIV with programming. That's right, programming dedicated to human rights and social justice, WHIVFM.org. We honor independent voices. We are not a radio station with a mission. No, we are a mission with a radio station that is to end all wars. Welcome to COVID NoiseFilter, the once daily, then thrice weekly, and now just straight up weekly podcast show, radio show, streamcast show. My name is Dr. Mark Allen Dery. I'm an infectious disease doctor. Co-hosting with me, as always, is your friend and mine. Sitting across the digital divide is Dr. Eric Griggs. Say hello, Doc Griggs.
Hello, Doc Griggs. How are you?
How are you, Eric? Where are you? Are you at the CAC on the roof?
No, I'm at my friend's spot around the corner on the patio by myself. I wasn't gonna make it home, so I had to make a detour. There's music in the background, so I'll go mute as much as possible, but I want to make sure we're on time.
Right on. Excellent. Thank you very much. I have a meeting at 7, so I had to jump on. We had some technical difficulties getting on. We are
hard stop today. Hard stop today, guys. We're gonna get it in. I'll put it that way.
Yeah, we'll get it all done. Let's see. We had some technical difficulties, so we are on. Thank you so much. If you are watching, and I'll say this a couple times, please share and like this stream. Eric, definitely go ahead and do all your magic to share on your Facebook as well. We do appreciate it. Sharing and liking the stream will let other people know that we're on. I think because we are COVID centric, I think algorithms don't like us, so please help us get around those algorithms. And so with that being said, Eric, it's an interesting week. I think if I were to summarize, I think we've kind of turned the corner a bit. I feel good. I feel optimistic about things, and I have a lot of data to show why I feel good and optimistic about things. And probably the first time I've felt good and optimistic in a long time now. So with that being said, Eric, anything to update us on? What have you been talking about on the news lately? What are people in the neighborhood talking to you about?
Yeah, the latest thing, I had an incidental. It wasn't incidental. It was very intentional. I talked about high functioning depression, and it kind of low key went viral. Like I got a lot of likes and like over 31 shares or something. People are tired, and there's a lot of underlying issues going on, anxiety, depression. So it needs to be talked about as it relates to COVID, but people are tired of talking about COVID, let me tell you.
I know. What does that mean for us, dude? What are we going to do?
Keep talking about it because it's not going anywhere. It's not going anywhere. But we need to address that elephant in the room. That is the fact that we're tired. We need to talk about being tired. And I know we've shared over the course of the last 2 years. I'd say, folks, we've given you about 50% of what we've gone through personally with this, and we don't have to go into 100, but it's taken its toll on everyone. I think you told me, was it last week or the week before, about your colleagues at the hospital, how they're done.
Yeah, they're definitely done. The fatigue in the eyes of my colleagues. I've been getting more and more calls to cover more hospitals. I'm getting recruited with all of the locums folks. I'm on an ID locums list, and they are in desperate need of physicians. I think people are just really, really tired. I think we are seeing an exodus out of the healthcare field, which is really unfortunate and is a shame. But I can't imagine doing anything different. People are leaving the healthcare field. You can find another profession. More power to you. I'm one of those folks that I think I'm going to retire. Do you remember that doctor at Tulane? I'm sure he was there when you were there. Older guy. I think he may have been a cardiologist back in the day. Tall, really thin. Had very pale skin, and they used to call him the Ghost. Remember him?
Ghost.
Ghost. The Ghost.
Yeah.
Yeah. And so that's going to be me. But you know what? A good friend and colleague, somebody I used to work with a long time ago and still do. Sharon just jumped on and said, it's a shame I'm leaving healthcare too. Sharon, do you mind jumping on real quickly, I'll happy to send you an invite if you want to share that story, or if at least tell us why, if not jumping on, or even just through text, at why you're leaving. Sharon is, would you rather text it to you or email? Sharon is the head of infection control at the Ochsner system, as an incredibly talented nurse. And there it is, it's burnout. And so especially with an infection control nurse, Sharon, I'm gonna text it to you via your cell phone, and you can just kind of click on with your cell phone. It'll be a link, and we would love to hear from you, to hear what's going on. This is a really great, y'all. This is totally not planned. This is what's great about our show. We have great guests who come on and give us real kind of spur of the moment. What's the word I'm looking for? Person on the street, kind of very spontaneous.
Literally from the front line. I mean, she's an infection control nurse. I mean, there's no more, outside of you being an infectious disease doctor, there's no, you can't describe a healthcare professional in this pandemic in any other way.
Yeah, absolutely. So
respiratory therapists get it bad too.
Respiratory therapists, absolutely. So while we're waiting for her to jump on, any other things that you're in the community stuff? I mean,
no, people are over it. They're ready for Mardi Gras. They're ready to release. I don't want to pour any water on your optimism, but I'm afraid with the lifting of mask mandates. I personally think that we just need to wear masks for a while until we're sure. You know what I mean?
We're going to get to that in a quick second. Everybody, this is Sharon Berry. Sharon Berry is an incredibly talented healthcare professional. I worked with her for years in infection control, a nurse at Ochsner Healthcare System, managing infection control. Sharon, I thank you so much for jumping on. Can you tell us what's going on?
Sure, Dr. Dery. So I, over time, and just like we hear, it's burnout. I'm actually the director of employee health. So
I'm sorry, director of employee health. My apologies.
Yeah, so I work very closely with infection control, but my job is to ensure we have a healthy workforce. So I usually tell my team that we're the heroes behind the heroes, because we want to, make sure that they're taken care of, or they're tested, we get them back to work as soon as possible. But fourth, fifth surge, it's so tiring. And the administrative part of our job is like mostly the administrative part, but just the pressure of, can this person come back in? And then the employees are sick, unfortunately,
Right.
So
right.
there's a mixture of that, and it's just it is tiring. It is exhausting.
I mean, before it was challenging for you to have to give everybody an influenza vaccine. What was it like having to do that with a COVID vaccine?
Oh my gosh. I mean, it was, it's funny because I didn't realize or expect the amount of pushback with the COVID vaccine. It still shocks me, but I guess, with flu, now it's like flu is more, people will get the flu. I mean, we'll take the flu vaccine, but it was hard. Trust me, there's a lot of the pushback, I think, is like politically motivated,
right?
Unfortunately.
Right.
So,
but now everybody at Ochsner is vaccinated, probably with a very small minority, maybe some religious exemptions or maybe some medical exemptions. Have you seen that the workforce has been healthy as a result of that? Like, there's been, I mean, obviously with Omicron, people were getting infected. And so, but people did you notice that the severity of illness was less? Because I mean, that's what I noticed.
Yes. Yeah. Sorry about my dog, you guys.
That's okay.
But it's a lot. I've heard from a lot of people, they felt like it's like a cold. And I think it's because they're vaccinated.
Right.
It's the ones that are not vaccinated that get more severe.
So what worries me about that is I think that's the setup, right? That's the trap for the next one coming. I've been doing a lot of reading lately about the pandemic of 1918, the unfortunately misnamed pandemic. And there was a fourth wave that was more devastating than the first and the third. More people died than the first, second, and the Korean Wars. 675,000 people in the U.S. from the flu. Like we've not talked about that statistic in the last
Mhm.
24 months, Mark Allen. But
we talked about it when we surpassed it.
yeah, we did. But the thing is, we didn't talk about the human behavior. What's amazing, but disconcerting is the fact that the human behavior is the exact same.
Yeah,
It's the exact same.
It just
Mhm.
goes to show that S doesn't change. You know, like, S doesn't change no matter what. Even though we're separated by 5 or 6 generations, human beings are human beings. We're mostly ignorant and don't care. And Griggs, if we have time, Eric, if we have time today, I'm going to tell you about a interview I did with a nurse from a region of the state who is very anti-vax. We tried to use it as an interview for the podcast. It did not work. We decided not to air it. But if we have time, I'll share with you. But even amongst smart people, even amongst people for whom is our privilege. She's a privileged person, obviously educated, has a good job, works as a nurse in a hospital system here in Louisiana. Her thoughts on the vaccine were so, like, 1835. It was just like,
Archaic.
so archaic. And the only thing that I could do was just show inconsistency of thought. Very much, the nurse kept saying over and over again, my mask, my face, my body, my rules, that whatever that thing that they say regularly. And then when I asked about reproductive rights, it was like, oh, no. So I was like, this is right. This is inconsistent. You are asking to not be mandated, or you're asking that people not be vaccinated, but then yet at the same time you're trying to mandate forced births. And that inconsistency of thought, it was like, yeah, okay, whatever, and just moved on. And it's just it's frustrating. It's frustrating to deal with this, but and I have a ton of data to show who's being hospitalized. Obviously it's unvaccinated. But I mean, we, Sharon, when we started the podcast and when we started the streamcast, we knew that there was going to be pushback. I just don't think there was going to be that's why we called it NoiseFilter. I just don't think it was going to be to the level that we've seen it at. And that has been difficult. It's been difficult, I know, for Doc Griggs. I'm not going to speak for him, but I know that it has. It's been difficult for me, and I'm sure it's been difficult for you to say the same thing over and over again, oftentimes to the same people who refuse to listen to the major points that you're making. And this comes down to, and I won't filibuster, and I'll move it over to you guys. This is my last point, that we live in a me society, and I wish that we live in a we society. I wish that we could do things like in other countries that recognize, I'm going to put a mask on and I'm going to get vaccinated because it's going to protect the community. And I want the community as a whole to be protected. And that's just not who we are as a society. And I think that's a shame.
Dr. Dery, I also wanted to add too, part of the frustration that a lot of the nurses are feeling right now is, obviously there's a shortage, right, in the workforce. A lot of my colleagues are, upset that they're seeing, we have a lot of agency nurses.
Travel. I knew.
Yes,
I knew you were going to say that.
We welcome agency travel nurses, right? Because
they're getting paid. They're getting paid bank, aren't they?
Oh yeah. And I had for example, I had a colleague who was a charge nurse at one of the EDs, right? And she's saying she walked in one day and there's 6 brand new travel nurses in her unit, and she's charged. So not only do they are not used to the Epic system, they don't know where anything is, and yet she's having to support 6 brand new nurses on her own and take care of sick patients. So there's a lot of that. And other nurses saying, why shouldn't I travel someplace and make $15,000 a week or something ridiculous like that?
Sure, Sharon. There's a point that I make on the podcast and as well as on the radio show and obviously here, and I just want you to kind of help paint the picture a little bit more clearly than I can. Yes, the healthcare workers, heroes, whatever. That's in one ear and out the other. That means zero to me, right? And yes, I look at my colleagues and I see my colleagues, and yes, as far as I'm concerned, they're heroes and the doctors or whatever, but help people understand what it's like to be a nurse in a COVID ward wearing the Tyvek suit, the respirators, and they're in there for 12 hours a day. When I'm in the COVID ward, I'm in there for a few hours. I'm wearing scrubs, a blue, PPE. I've got an N95 on. I've got like some goggles. I got like easy gloves, and my work is very, very minimal compared to the amazing work that these nurses are doing. And somebody on the front line who's a nurse, maybe help our listeners and viewers understand what that job has been for 2 years for these nurses that have been in the COVID wards.
Yeah, well, that's a good point, Dr. Dery. So I really can't speak for the actual floor nurses because I don't do that anymore, but I do hear and listen to them. And you're right. When they put on the isolation gowns, the PPEs that they use, they almost have to time their time in that room to make sure that they have every single thing, because you can't be running in and out missing a medicine or something when you go in there. But to constantly be watching how to don and doff on the frequent level of that, and it's hot, and then on top of that you have family members, if visitors are allowed, that you're having to care for too, in a way. It's it can be really frustrating, and you almost I can't like, again, I can't really speak for them because I'm not bedside anymore, but that is what some of the complaints or at least frustration I've heard from other nurses where I work.
Absolutely.
What I'd like to hear from both of you though is the experience on the floor. Mark Allen, we talked about how frustrating it is. There's nothing that you can do but watch, right? When you're working in the COVID wards.
Yeah, I mean, you throw the kitchen sink, and you've heard me say that as an ID doctor. It's been very, very hard because as they're starting to die, it's so hard to figure out, are they dying because of COVID, or are they dying, or are they doing poorly because there's an infection I'm missing? And that's the thing that is so incredibly difficult. Obviously, we want nobody to die, right? But we know that there's a mortality rate associated with this virus. We want nobody to die. And I'm sitting at the bedside, turning them over. Is there a rash I'm missing? Is there a cellulitis? Is there a line that's in the groin that somehow we all missed? All the things that are reasons for infections. But, I do that, and I do that every day with every single patient. I do a head to toe to make sure that I'm not missing anything. And then oftentimes, despite the dexamethasone, despite the remdesivir, despite the baricitinib, and all the other things that we try to do, there's nothing that you can do. And it's very, very hard to watch. And I'm sure, I know, Sharon, that you're not a bedside nurse anymore, but I'm sure you've seen it from the sidelines as an employee health nurse. And I'm sure you've seen employees get sick, especially at the beginning of the pandemic.
Yeah.
Your employees are going to obviously utilize the services of the hospital. And before a vaccine, that those are difficult to watch our colleagues succumb to that. That's difficult. And as an Ebola physician, I have seen that, and that's a difficult thing to see. And it's hard to watch, because you never know when that little fever that you have may be the temperature that you have.
And there's also emotional fatigue,
which is what I'm assuming. Is that what you're experiencing then?
Yes. Yeah. I mean, it's frustration. It's a whole lot of different things, and politics within the healthcare system too. I mean, there's a lot of factors that play into this, but I feel like, I recently resigned from Ochsner, just so you know.
I figured it was open because you wouldn't jump on a play.
And so, and I mean, it's sad. It makes me sad, but I'm hoping that, at some point, sometime, I will go back to healthcare. But right now,
what are you going to do?
I'm actually going into like a software, well, in a down low kind of, but in a software company, using my clinical expertise.
Congratulations. That's great.
Thank you.
That's great. And like you said, down low, so we can't talk more about it. Maybe I'll call you on the side and hear a little bit more.
Sure.
But congratulations. And Wait, are you done, or are you? Do you still have more time at Ochsner?
I'm done. I actually just
Wow, you're done. Jeez.
I'm done, and I'm so happy.
And do you know other nurses that are also resigning?
A few, yeah, a few, but I don't, I don't know if I don't know if they're leaving healthcare, but they're definitely, leaving organization.
Yeah,
So,
that's a shame.
mhm.
Eric, anything else before we continue on with our show?
No. Just thank you for joining us. I mean, it's good to
Sure, you
hear that
guys.
perspective.
Thank you guys for doing what you're doing, Dr. Dery. You're amazing.
Thank you. I appreciate it. Thank you so much for doing what you do as well. Thank you.
All
Bye-bye.
right, bye.
All right. Wow, how fortuitous was that, Eric?
That's pretty. Yeah. I mean, that's kind of the way that we've been rolling with
Yeah.
it. I'm glad that she came on. Unfortunately, hopefully it'll be a break, or it'll be something that she wants. We just want everybody to be happy, but to
Right.
be safe. I mean, this has been taxing. We've had our times with this.
Right. Right. Absolutely.
I think she's going to be awesome at whatever she does.
Yeah. I hope Sharon, I hope you do well, and congratulations, and we'd love to have you jump back on at some point in the future if you want to share with us which your successes have been. Eric, there was a couple things I wanted to share with you before we actually started with the data, because I've got a lot of really good information to show you. But one of the things that we've been seeing, and this is what you started the show off with, was that we are seeing states lift mask mandates. And here's your states that are lifting mask mandates. You have the governor of California, this is a different topic. It's 2 weeks of COVID-19 sick pay, which is great. Rhode Island is lifting mask mandates. So it's something that you mentioned at the top of the hour. And before I hold it over to you, I just also wanted to show you, here's another example of just really bad communications. The White House is saying students and teachers should follow CDC guidelines on mask wearing regardless of state rules. And I see what they're trying to do there, but I saw that and I was just like, come on, guys, that's not. Why are you doing that? Why are you going, again, you're sticking your neck out in a way. If the states are dropping it, I don't know. What are your thoughts here, Eric? What do you, I can see why they're doing it.
I just think everyone needs, there's a rule that my uncle taught me. He said, if you're really, really upset about something, before you act or speak on it, give yourself 24 hours. Think before you act or speak.
Yeah, there's a French proverb that says, twist your tongue 7 times before speaking.
Yeah, so I think they need 24 hours. It's just the communication divide. I mean, this pandemic has exposed a lot of difficulties and a lot of kinks in the system. So I think there needs to be at least 24 hours to talk with everyone in the room before there's supposedly a unified message, before you try to get 335 million people to act on one accord. I just think there needs to be more conversation about how we communicate. It's called health communication, public health communication. It's literacy. It's where we live. It's our area of expertise. I tell people all the time, I live in the lane of health literacy. More importantly, health communication. I'm talking to large groups of people, making sure that they understand the message and that it's consistent and concise, and to get the feedback from everyone to make sure that the message was conveyed that I meant to convey. So, well, we're going to see the fallout. We've been seeing, you and I, on the front lines of this and being forward facing, have dealt with a lot of fallout of just communication divide. So we'll see what happens.
It has been the most difficult thing I ever experienced. Like I was saying, like this interview that I did sometime just recently, rather, with a nurse in the state of Louisiana, and just to hear the sheer misinformation, misunderstanding, and despite a number of times of me correcting the individual and trying to set some of the facts straight, it was in the end, well, you have your facts and I have my facts. And I was like, No, that's actually not the way it works. We, as a functioning society, need to agree that this cup is blue. You can't call this an orange. It's not an orange. You don't eat this. It's a cup. You put fluid in it, and it's the color blue. And that's where I feel like we are as a society. I know this is a bigger discussion about bigger things that are happening, but certainly COVID is a good analogy or metaphor to use because of where we are in terms of just having completely different languages and different ways of looking at things. But of course, keeping this to COVID.
Yeah, but we're at a different point in the pandemic now. I don't argue with anyone anymore. I don't even debate anymore. If that's the way you should choose to feel, and you have your facts, I have mine. That's fine. I'm going to be here with mine in the end. And if and when you need to get tested, I'll be here. If and when you need a vaccine, I'll be here. If and when you get sick, I'm going to be here regardless, with the same group of facts that I've spent $500,000 in over 25 years in the field of building a life on, that happens to be congruent with the facts and data that keep coming in. So I'm not going to argue. I'll be here, but I can respectfully agree to extricate myself from this situation, because my grandmother said, if you argue, spend your time loudly arguing in public with a fool, someone walking up won't know who the fool is. And actually, it's both of you, because you should know better. That's an anime-ism.
That's that is an anime if I ever heard one, and we haven't had her on the show for a while, so I always look forward to her wisdom appearing whenever possible. All right, so I have some cool stuff to show you, Eric. You're going to be super impressed with some of this stuff. So let's go. So first, we're going to talk about again, everything here is by Caitlin Jetelina. She has a website, or a Substack rather, that's called Your Local Epidemiologist. Please subscribe to her. As I've mentioned, I don't have the time anymore to make slides and go through the literature like I used to, so I kind of lean on her Substack, and she has really, really great information. So what she is talking now is about a framework for the future of SARS-CoV-2. So one thing that's consistent is that we have these peaks of every wave. Then after that comes a highly charged debate on how we move forward as an individual, as a community, as a nation, and as a globe. And so, of course, the issue is it's not if this, then that, or it's one side or the other. It's, as Eric always says, yes and, yes and, yes and. It's much more fluid. It's much more gray. And so she ended up coming up with a table that I just think is brilliant, that as when we were doing more work regularly with the city and for the mayor, one of the vice presidents of Ochsner, Leo Swanee. Eric, this is one of the times when you came down and all the boards were all full of stuff. My wife, Leona Elliott, and I came up with something which we referred to as snapback parameters. What are we going to do? What are the parameters that we're going to look at? And now this was, probably early summer of 2020. So we didn't know a lot about the virus at that point, certainly not as much as we know now. But this is her iteration of snapback parameters. And this is why, Eric, when we talked this morning, this is what I was saying. I'm super excited to show you. Okay. So this essentially what we're looking at here, and she calls this riding the waves, right? So implementation or de-implementation of public health mitigation layers. Okay. All right. So if you're in the red right here, that means that your county or your case levels are greater than 100,000, are greater than 100 per 100,000. Your test positivity rate is greater than 10%. At that point, we should consider masking immediately. We should recognize that in terms of antigen testing and you're symptomatic, trust your negative results. And if you're positive, trust those as well. If you're in isolation and positive, you want to test to exit exposure. If you're not boosted, quarantine for 5 days. But essentially here, what she's essentially, and then also what can you do? So examples of activities of not sick. Essentially, if you're in an area where there's a lot of cases around, Avoid indoor crowded public areas where not 100% masked and vaccination status unknown. Avoid flying if possible. Extra vigilance around vulnerables like grandparents. Avoid indoor dining. Avoid indoor high exertion public activities like trampoline parks. So this is if you are at the highest level. Now, orange would be cases between 50 to 99 per 100,000 over 7 days. Test positivity that takes you to about 8 to 9.9. Yes, you want to mask indoors. Masking indoors is appropriate. And what are things that you can do? Again, the recommendation, avoid indoor crowded places. We're not 75% masked. Flying, okay. Vigilant around vulnerables. Indoor dining, okay. I'm not 100% sure I agree with that. Yellow is 10 to 49. So 10 to 49 cases. So just to give you an idea, where in New Orleans, so just to kind of give you an idea, we'll get to this in a second. In New Orleans, we're at 52.3 per 100,000 over 7 days, and we have a test positivity of 5.7. Now, of course, this is not neat. It's not going to fit into categories that are neat, but essentially we are in the orange, as you can see right here, with a test positivity rate that's probably a little bit lower, but we're slowly moving into yellow. And once we get into that yellow, what are things that you can do, right? Indoor crowded public events, okay. Flying, okay. Vigilant around vulnerables, what have you. And then blue is when you have less than 10 per 100,000, less than 5%. And here, there's really no limitation on activities. So I think that this is a great table. I think it's a table that can be formatted by a graphic artist that can actually make it a little bit nicer. But I think moving forward, these are the sorts of things that you've always heard me talk about risk mitigation. I think these are the things that we're going to need moving forward. So what are your thoughts on that, Eric?
No, I think it's brilliant. I think there are certain things I don't necessarily agree with, but they're not major. They're just it's just
right.
Some of the indoor dining. Yeah, but I think it's brilliant overall. I think it's brilliant. I think it's great.
So she's gonna now want to go over the assumptions that she's making here, which I think is fair. So some of the assumptions she's talking about is, is this framework good for individual level? And what she says is, as a public health official, I don't necessarily think that individual level solutions are effective, that we need to be thinking about more public health effectiveness, of which, of course, I 100% agree. The framework is anchored by cases. Excuse me. Which is so incredibly important, because without understanding the number of cases, we're not going to understand what kind of transmission is happening. And here she throws up a CDC slide just showing that to a certain degree, we're still kind of in the highest amount of transmission pretty much here in the US. She's looking at a vaccination rate of 85% of the total population. She says she included the vaccination cutoff of 85 to indicate removing precautions regardless of case rates. Several countries like Sweden and Denmark are lifting all restrictions, and their vaccination rates are high. And then what she points out is that when you look at the U.S. when compared to other countries that are highly vaccinated, namely Denmark, Portugal, and Sweden, what you can see here, you see Denmark is the highest, Portugal's the second highest, Sweden is the third, and the U.S. falls underneath. When you look at new cases per million, the U.S. just far and away blows everybody away. I'm sorry, this is Denmark. Denmark blows everybody away, with the U.S. following suit. But when you look at patients in the ICU, you've got far more people that are in the ICU. This is likely to be because we have a less vaccinated population than the other three countries here. And when you look at deaths, we have the highest rates of deaths compared to these countries as well. And again, this is very, very likely secondary to the fact that we have a very poor vaccination. So, Eric, if you ever want to say anything, because I can't see you, I'm on another screen, just stop me. If you
keep rolling out. I have ambient noise going on. I'm really interested in these.
Got it.
Graphs.
All right. So what this graph is showing is that it's looking at if if the U.S. had the same level of vaccination that that Denmark had, what mortality rate be? So this is what our mortality rate is. This is what happened with Delta, and then here you can see Omicron. So these are deaths. Okay. Is this deaths or I apologize. These are hospitalizations. So you could see increase. This is Delta, and this is what Omicron is for hospitalizations. But had we had vaccinations, you could see that the numbers would be halved. If we had the same level of vaccinations as Denmark, our hospitalizations and, of course, our mortality rates after that would have been halved. So really interesting graph to look at and to obviously think about. So here she's talking, more about things about a community level and activities. And here the final conclusion is that we need a framework that accounts for an uncertain future. Maybe this was our last wave, likely due to the fact that between people who have been unvaccinated and infected, so they have natural immunity, or vaccinated or boosted, I think that, and she agrees, that hopefully this is the last big wave that we see. Of course, we can see more in the setting of new variants, but hopefully there will not be vaccine evasive or immune evasive viruses. And as Eric says, that they would do their homework. They've learned the lesson that viruses should become less virulent over time rather than more virulent over time. And we start to approach a little bit more of what we used to refer to as normality. Thoughts?
Yeah. So I mean, there's nothing else to say. Yeah, that's our hope. We won't know until we get there. I'm just nervous. I'm cautiously. I can't even say optimistic or pessimistic. I'm just cautious. We've been here too many times before. My fear is that we do have a big party coming up, and everybody coming into our house, hopefully not messing up our things. That would be Mardi Gras. Following the rules, bringing a minimal number of bugs and hopefully not a new variant to us, and leaving us with whatever they dropped here. And we don't have a mild surge. Hopefully it would be a mild surge locally, because immediately following Mardi Gras in the next month, we begin, in New Orleans, we have different seasons. We have the holiday season, we have Mardi Gras season, we have festival season, we have football season. So we immediately go from Mardi Gras, because it's late this year, to festival season. We're already talking about the French Quarter Fest, Strawberry Fest, the Oyster Fest, the Blues Fest, you name it, Jazz Fest, and then right after that, Essence Fest, and then there's football season. So I just hope we don't drop a pebble in the middle of a pond that ripples out to make more waves and surges.
Yeah, I mean, obviously 100% agree, although I think that we are going to see, as these festivals come through, I think we are going to see more cases, but I think that it's going to be doable. I think that hopefully that we're not going to see the crush on the healthcare system. But we'll see. I mean, obviously that is as of yet to be determined. So Caitlin Jetelina did a great write-up on surveillance. And as you know, Eric, what's the thing that I love the most about surveillance? My favorite surveillance tool is wastewater-based epidemiology, or what you'll hear me refer to as wastewater management or wastewater surveillance. So she says that it's being conducted in over 3,000 sites in 58 countries across the globe. But in the U.S., active wastewater surveillance for SARS-CoV-2 is only done in some states. And the CDC showed our system by adding wastewater surveillance to the COVID-19 dashboard. All right. So you can see these different cities that are using wastewater surveillance. And just as a reminder to what is wastewater surveillance, because we can't get everybody tested, because not everybody does get tested, because we don't have an accurate number of what the virus is. The one thing that everybody does do is, as the book tells us, everybody poops. So go ahead, Eric.
Just the community medicine Twitter version, it's passive testing from the other end.
Because you carry a viral load, the virus is dispensed or is transmitted through your stool, which then gets of course into the wastewater, and then essentially what you could do is just take a sample of the wastewater and you can measure viruses in the wastewater, and you can kind of determine where you are. You have some metric as to there should be this amount, but then once it starts to creep up, and so these are some examples of that we're going to see.
Passive testing of communities from the other end.
Did you just come up with that, or had you been using that?
No, we did a story. I did a story on the wastewater, this whole thing when the CDC added it, and that's basically what it just boils down to. It allows you to detect, especially finally people started to understand that this virus with Omicron, even though it's been like that you could be infected without showing symptoms days before you show a symptom. It allows you to test what's going on in a community prior to, and if the numbers are up, to set up a testing site in that community and possibly quarantine that section and segment of the community from the rest of the community based on what you see. Even though it's on the back end, it's on the front end before things get bad.
So you're saying the back end helps up on the back end, right?
Yeah, the back end is always necessary and essential.
So listen, this has been something that I've been doing for a while. The methodology started in 1984 to trace parasitic infections. It wasn't until the 90s that there was greater interest. They can look at changing habits of illicit drugs, global eradication of polio, surveillance of hepatitis E, changes in dietary patterns, and surveillance of pit latrines. And so you can see, just basically checking poop just gives a lot of information. And in this case, the information we're looking for specifically is looking at the surveillance of the SARS-CoV-2 virus, the virus that causes COVID. Okay, so there was some articles that were published, particularly in the very prestigious journal Lancet, and essentially what they saw was that the number of positive cases estimated from wastewater was orders of magnitude greater than the number of confirmed clinical cases, and therefore may significantly impact efforts to understand the case fatality and rate of progression of disease. Eric, do you want to do another Twitter summary of what they just said?
I just saw that the number that it just shows the importance of wastewater management. The higher the levels, the higher the levels.
Absolutely. Essentially, what they found was there was a lot more cases in the wastewater than they were seeing in terms of the number and the charts that we show you guys. So wastewater management is incredibly helpful.
Passive testing from the other end.
There you go. Passive testing for the other end.
That paint a true picture.
So it was heavily used during the Omicron wave. And here what they're showing here was this is your Delta virus. The squares were the actual cases. The Delta virus in South Africa, you can see in the wastewater management went up. But what they started to see sometime in late in the year was a new virus emerge, and they saw this increase. And this increase, of course, was Omicron. And they were able to basically tell the world, here you go. Because of this, South Africa was able to warn the world of what was to come. So you can see that something like that is just really tremendous. You could see here in the Twin Cities in Minneapolis and St. Paul, you had increases in their surveillance in terms of being able to surveil wastewater, and you can see the cases went up, or evaluation. They were able to detect more virus in wastewater that correlated with the increase in cases. So there's benefits and limitations. Of course, it's passive. In other words, you gotta wait for the data to come to you, so to speak. But I think it's so strong because everybody poops, essentially. Okay. The other thing too is that you can do time timely genetic sequencing. In other words, you're able to sequence viruses in a timely manner to make sure that you are being able to determine. Here in this, here you have the individual, here you have the community. Here, if you detect, or when you detect, genomic sampling will allow you essentially to determine if there is a new variant. And so that new variant is important, and you can see how the cycle just starts all over again, because that variant is able to let us know that we need to be careful, maybe go back to masking and this sort of stuff. Very, very positive in terms of people saying that they agreed with the importance of wastewater management as well. And then I think lastly, there's no doubt that wastewater surveillance continues to strengthen our public health systems. It brings equity in an anonymous, passive, bias-free, acceptable public health way. And I really hope to see wastewater surveillance grow as a result. So I think wastewater management is super interesting. It's super cool. And I think that's something that we should be doing. And I think I did ask about it in the last time that I presented to the mayor's office. And I think that the idea was that this was something that they were looking into, but not quite yet had decided to do. Are you familiar with any of the stuff that's going on with that?
I don't know. I don't know what's happening locally, but I know you and I have been talking about this since the summer of 2020 when they started considering that, doing it in the UK. I remember the article. I remember the conversation, and it was gross but cool. That's what we said it was back then. Yeah, and necessary, as we're seeing now.
It was gauche but cool.
And they started doing it at the colleges. Remember?
Right, they did it at ASU, at Arizona State University.
Arizona State. Yep. And I think it's more prevalent than the numbers that she's presenting based on the article. Like, I think there are a lot more states that are involved because they see the importance of it. And it's relatively easy compared to try to compel people to get a swab put up their nose, and the genetic surveillance is a lot easier.
It's super cool. And everybody, you guys heard it from Doc Griggs here first, where he just said stool, gauche, but cool.
That's so bad. That won't even make the cartoon. That's not even going to make the editor's floor of a cartoon. That was horrible. That was bad. That needs to go into the wastewater so we can surveil it for bad jokes.
All right. As we turn the corner and wrap things up.
That one smells.
Thank you. I appreciate it, Sean. Thank you. At least we get a little bit of love. I know it stunk. Okay, funny. But you know what I'm going to do? I'm going to give myself this. This is what I get. A mic drop. Stool. Gauche, but cool.
If you want a mic drop to your stool-smelling joke, that's all on you.
All right. We are infinitely teenagers at heart. My wife calls me a perpetual 14-year-old. Are you accused of continually being a teenager?
No, you're much older than I am. I'm still a preteen, so yeah. They call me a kid.
All right, as we are rounding the corner here and wrapping things up, just kind of going over some basic epi here. So global epidemiology. Look at this, Eric. What is that? That's 4 million. That's 4 million. No, that's 400 million. 400 million, right? That's 400 million, right? I'm reading that right? 400 million, 403,310,189. Oh, geez. 5,793,014 deaths. I am reading that correctly. That's just
that's 5 million deaths worldwide, 403 million cases worldwide, and that's since the beginning of this thing. So,
and last night, how much did we add? We added 2.6 million cases last night, with 12.6 thousand deaths. Deaths are going up, folks. But I think I can finally. Can I make it a call, Eric? We are on the back end of.
Don't do it, folks. He did it. Oh well, there we go. Yeah, even though I think it's safer to do now.
Yeah, I think we are on the back end of this epidemic globally. This is what we're seeing here is that cases have peaked out and we are starting to see a change. The 14-day change is down by 22%. So you can see that we are definitely, globally speaking, on the back end. I'd like to think, I'm almost positive that we are on the back end of this epidemic, or this current epidemic. And I think that things are going to start chilling out. But we are seeing the lagging indicator, that pesky lagging indicator of deaths of being almost at 30%. This is really, really, really a shame. Here's the epi curve, and you can see that the epi curve mortality is going up. And again, this is largely a function of the fact that we have so many people who are sick. You are going to just see some people who are going to get sick and die. Globally, these are very likely to be unvaccinated, because we still have very, very poor vaccination rates globally. And I wish that wasn't the case.
So an important thing to remember, though, folks, even though you see things going down as high, exponentially high as you think, all the numbers that you saw us go through on the way up, in order for us to go back down, unfortunately, we have to go through those same numbers. So you're going to see alarming numbers of deaths, because it's such cases, 2 weeks hospitalization, 2 to 3 weeks deaths.
Yeah,
it's been the pattern this whole time.
Absolutely. This is basically looking at cases by region in the world, and here in red is the US and Canada, and you can see those cases have gone down. You can see other regions of the world. Latin America, green, is going down. The Middle East appears to still be the one that's going up. It hasn't peaked out yet. Asia Pacific, it looks like, had a very low peak, but the one that rivaled the US was, of course, Europe, and it just looks like it just recently peaked out, and it looks like we're on the other end of that curve as well. But really, the US appears to have truly peaked out. We'll look at that in just a quick second. This is, of course, looking at hot spots around the globe. We've been looking at this map for some time, and again, what we see is the US, South America, Australia, New Zealand, all of northern, central, eastern, southern Europe, all the way into what is Russia as well. And so some of the hottest spots on the globe as well. And certainly something to consider. Now, looking at the U.S., we are known, this is a gross underestimation, of course, 78,746,484 cases. Deaths, we will be hitting 100,000. We'll be hitting 1 million. There's no question.
1 million.
Yeah.
1 million.
934,438. We added 179,395 cases last night, with number of deaths of about 1,700. So this is what the epi curve looks like. And this is what kind of gives me a little bit of hope. I think that other people around the country are looking at this and they're like, let's go to New Orleans. What's the big party that's coming up in very soon? Let's go and let loose over there. Testing still going up, which is great, because we want as many people testing as possible. Hospitalizations appear to have peaked out, and just as a hospital worker myself, that feels about right as well. Deaths hopefully have peaked out as well. You can see that's still up about 9%. In terms of those that have been fully vaccinated, only 64%. So we still, and just like Eric said, if you haven't been vaccinated by now, I'm not sure what else we're going to be able to say that's going to convince you to go and get vaccinated. As looking at the regions of the country, you can see pretty much everybody's peaked out, north, south, east, and west. And then looking at the hotspots of the country, you can see that things have kind of chilled out. Maybe things are moving a little bit toward the west a little bit. Maybe some of the states that are traditionally red states, quite literally, are still a little bit hotter. Louisiana, unfortunately, is not quite as yellow as I want it to be. but I know that we're moving in that direction. So I think, I started off this hour by saying I feel kind of, hopeful, and this is one of the reasons why I do. Now, this is looking at rates of vaccinated versus unvaccinated. And of course, here you could see people who were not vaccinated had twice as high of cases of those that were fully vaccinated, and looking at deaths, 20 times as high likelihood of dying if you're unvaccinated. So this is a really nice graph that I picked up today from the New York Times. In Louisiana, 1.2 million cases, 16,000 deaths. We added 2,500 cases yesterday, which, if you look at it, is the lowest that we've had in a long time. 63 deaths, and you can see it appears that we had some little fits and starts of when the peak actually happened, but it looks like this peak's actually happening with 21% change. In other words, with negative 21%, in other words, that the slope is going down. Testing is down just a little bit, as you can see here. Hospitalizations appear to have peaked as well. It almost peaked at the same level as Delta, and then deaths, unfortunately, still going up. And one of the things that we talked about too is masking mandates, and we're seeing the state masking mandates starting to occur around the country. So with that being said, I will take it to our final slide here, in which what we're seeing here is that the state is now extremely high. It was severe for a long time. Number of cases are 90.6 per 100,000. Infection rate is below 1. Test positivity rate is 13. We want that obviously to be under 5. And then in looking at Orleans Parish, our case rates are going down significantly as well. As you can see, we're at 52.3 per 100,000. A nice infection rate of 0.63. Of course, we want that to be lower. Our test positivity is 5.7. So I feel as though we're moving in the right direction. I feel as though things are moving in a positive direction, and I do feel optimistic. So with that, Eric, I'll let you say whatever final words you have. Or
Nope, that's it, folks. Keep riding the waves. Health is a human right. If you're not vaccinated, get vaccinated and boosted. Wear a mask, and I want everyone to enjoy this Mardi Gras season the whole night, but just be cautious and be careful. Wear your mask if you're not around people that you know. We've done this how many times?
A lot. And it's Crew de Vue this weekend. So
Crew de Vue, wear your mask.
Have a good Crew de Vue. Please wear your masks. I know I'll be double masked out there.
Thanks, bro.
All right, guys. Everybody take care. We'll see you next week. Peace out, everybody.
Health is a human right.
Health is a human right. Get checked, get fit, get moved.